I'm Paul Babcock. I'm the Chief Financial Officer at Forks Community Hospital, and we're very similar in size to Lincoln, and often I look at their DOH reports to understand our similarities. We're about 245 FTEs. We have a 20-bed long-term care facility, 17-bed critical access hospital, 3 RHC clinics, two that are in town and one that's about 29 miles away in Clallam Bay. We also have an ambulance service, the only one in the area. We have a very large geographic area, and we are pretty far from anywhere else. The nearest cities to us are Port Angeles, which is sort of to the northeast of Forks, and it's more than an hour's drive, sometimes worse depending on the road around the lake. And then to the south of us, it's 2 hours to Aberdeen. So it's we're kind of out there, but we do have that competition as well with both of the large hospitals that are in those cities. So and a lot of people that are in between.
I'm Tom Legel. I'm the CFO at Confluence Health, and we're an interesting organization. We cover 12,000 square miles of coverage. We have about 260,000 people in that region that we feel responsible for. We have 2 hospitals, one large hospital in Wenatchee, one small hospital in Wenatchee, but we also have 12 clinics in 12 of those cities around those 12,000 square miles. We have around 4,000 employees, 300 plus physicians, 150 APPs, and we provide a wide range of primary care to specialty services. And the specialty services include behavioral health, open heart surgery, neurosurgery, and we think we're the referral center for those 12,000 square miles. We also have a Medicaid challenge because close to 20% of our revenue comes from Medicaid patients and 50% from Medicare, and about 23% are commercial lives to do that. So we have a very challenging payer mix as we go through it. But again, we also really feel responsible that we're the safety net and have the community responsible to make sure that our communities are cared for. And I think working with the health districts, we felt that we demonstrated that during the past couple of years with COVID. And I've been at Confluence Health about 2.5 years. I started March 1st. I brought COVID to Wenatchee, so that I'm well loved at the hospital. Nobody talks to me yet, but that's okay. But I've had a long career in healthcare. I've been a CFO for close to 40 years, and I never thought I'd be the oldest CFO in the room, but I think I am, and so in doing that. But again, I've been at larger and small facilities, but I think the role of the CFO, I think, becomes more and more important on a daily basis because we need to get involved in rev cycle, financial things at the beginning of things, not at the tail end as sometimes we get involved with it. So I think that the key is that we just need to keep sticking our nose into things to help make better decisions for our communities and for our facilities as we go forward.
My name is Becky Rudd. I am the Chief Financial Officer of Providence Medical Group out of Alaska. So what we are, we're the ministry, the arm of Providence up in Alaska that handles all the outpatient. We do primary care, we do behavioral health, and we do all our adult and pediatric subspecialties. We are the largest healthcare system in Alaska. We're based out of Anchorage, but we service the Mat-Su Valley. We have a lot of specialty groups that there may not be an exact demand, enough of a demand, but we really take it on as our community mission, right, to have as much specialty services as we can. So we manage a lot of community service and investment projects, and looking to expand our primary care is probably one of our biggest footprints right now in Anchorage.
Great. Thank you, guys. Awesome group. Okay, so the first question that we're going to go through is we're going to talk about meeting the market demands as it relates to wages and staffing. I know this is particularly something that I probably spend at least half my time on every day is understanding our staffing costs and thinking strategic about how we're going to bring some of those costs down. So we're going to kick it off with Tim to give his perspective. We are going to go down the line. We will not go down the line every time. We will randomly call on people. So be prepared. Watch out. What's that? You did. Yep. Exactly. All right, Tim, take us away.
Sure. So I think we've talked about now for a day and a half wages. We all know wages. That's an issue. So I want to talk about a couple of the other things that we're looking at within our shop. We're seeing a huge shift from full-time to part-time employees, especially some of our higher earning positions. A lot of our employees are established in life. They're earning enough now with part-time hours, either they're making that shift to claw back some of that time available to them, or they're making that shift because they can work part-time for us, collect benefits, and then maybe work as a locum or a traveler somewhere else. So we're seeing a huge shift in that. We're doing our best to try and build structure within our organization, within our benefit packages, to try and to retain those employees, get as much productive hours as possible. Looking at what our average benefit spend is per average FTE as opposed to per person. Probably the other big shift that we're seeing is burnout with our providers, burnout with our support staff. Production and our provider numbers are definitely dropping, especially in primary care. And we're working with them, looking at ways we can utilize different infrastructure or support services. We're looking at bringing in AI, scribes, basically, like an AI scribe type program. It's going to record the conversation for providers, trying to increase some of that productivity in the clinic and get them back some of their time. So that's just a few things that we're looking at and doing.
Yeah, like everyone else, we've had a lot of trouble with labor. We've wound up in getting to a point where our competition was simply outpricing us, in terms of wages, and we were losing nurses, we were losing staff. We've had, like everyone, have had difficulty in filling some of those positions. We had a wage reopener in our nursing contract this year, and we went high, but we did it really to be competitive for the first time, probably ever, for the hospital district with the market. But part of what we realized is we had to stop, some of the arguments that we'd used in the past, and stop our thought process of, we need to save money and need to keep the cost down, and realize that, if we don't have the labor, we're dead in the water. We have to have the labor here. So we've got to flip the script. We're dealing with burnout just like everyone else is, and part of that though was to, we're gonna get them where they want to be, but then they're gonna get more energized, which they haven't been in a long time. So I think we did that, but obviously the types of raises that we've done, it's not sustainable. We can't keep doing that, So where is labor going to end up in the next few years? I think some of that dynamic that's causing that shortage is still going to persist. I do think that some of what Marni described earlier in the introduction, that's going to, I think, cause kind of a pressure in the sense of that it's going to take away. You're going to see, we're already seeing cuts in services in the large systems. That's going to start taking away nursing jobs, and that will hopefully cool down the traveler issue that's been affecting so many of us. But we'll see if that pans out in the next year. But labor is a big cost driver. We know that. We know it's not sustainable this way. We know reimbursement's shrinking. But at the same time, we're a labor-driven industry, so we have to have it. So we have to meet that. And at some point, the payers are going to have to realize that. So.
No, and I would echo a lot of those same things. Our labor cost, our contract labor, through August this year, we have spent $42 million on contract labor. In 2019, through August, we had spent $2 million. So we spent $40 million more in contract labor than we had in 2019. And if probably for most of you, if you would take out the difference in the increase in contract labor than what you've spent before, you'll probably be hitting your operating margin targets where you thought you would be. So it is a labor issue. We're looking at a couple different things. One is recruitment is a big thing, but one of the challenges with recruitment is they're not putting out as many nurses as they were before. Some of that, I think, is the people don't want to go into nursing as much because it's a new wave. You want job flexibility. You want to be able to work from home. You can't do that in nursing. So I think that's some of the challenges. I think the other challenges we can all work together too through the legislator and through some others is the educators in the nursing schools. They do not make as much as a staff nurse. So why would anybody want to teach when they can make the staff nurse? And so I think that's a lot of areas where we can actually work together to really improve the wages for nursing educators so they can take on more nurses and enlarge the program. And I think the other thing for us, we recognize that we cannot go back to the way it was before. We have to redesign our care processes, look at different models, look at different staffing models, look at different, types of people to help us care for the same thing. Really use nurses to do what they can do, and then use other support staff to do some of those things, because I don't think no matter what we do, we'll have the same number of nurses or maybe even the CNAs. We really have to redesign in how we care for our patients, especially on the inpatient side.
Yeah, I would agree. One of our biggest conversations we have is how do we get everyone working at the top of their license, the top of their role. How can we ease their way? That's a huge Providence saying, is how do we ease your way? How do we get you doing what you're supposed to be doing so that we can all find our efficiencies, find our productivity, and kind of hit a stride. One of our biggest issues right now is the inequity, really in the new wage rates that are being caused with my existing caregivers. The gentleman from California talked about it a little bit, right? You're coming in, we have brand new caregivers coming in that are making more than people who have been here, and they're experienced and they're dedicated. And we spend a lot of time trying to figure out really the cost and how to retain and keep and find equity again that we can afford. The other big issue we have in Alaska is really the applicants. When we're really hurting, I found that we hire the people who show up, and that turnover really ends up costing us a lot. So we've created some programs where we have internships to build our own CMA population, right? How can we find a way to find someone who's already invested in us and already part of Providence, and find ways to help them kind of grow as an individual and in their profession. And we have nursing, we have University of Providence nursing programs. So constantly on the phone, hey, do you guys have your new cohort? How can we help? Just find ways to cultivate people who really want to be there and cut back on turnover.
Just add to that, one of the things that we've looked at is actually addressing the demand side from the patient perspective, right? So we have this influx of volume, this influx of long stay patients that are in our hospital, and how do we become better operators so that we don't have to staff those beds with contract labor? So some of the things that we're doing is putting in new processes around our ED admission process and making sure that there's maybe we're holding that admission until we have another level of review from a physician advisor before that patient gets admitted, so that we can reduce the number of social admits that we have. Also working really aggressively and partnering with post-acute partners to place patients in like a bridge bed program where they don't have a place to go, yet they don't need medical care in the hospital, but they're not quite ready to be on their own yet. So really focusing on the demand side. We're also doing similar things like looking at competitiveness of our, around those in the market. Also looking at labor targets within our individual nursing units. So a lot of our nurses are getting burnt out because we're short in lab and we're short in EVS. And so they're picking up the job that our support teams that we can't recruit are now doing. And so how do we make sure that we're giving nursing the appropriate resourcing that they need to be able to pick up the extra slack on the unit? We're also looking at redesign of care models. We're looking at robotic technology to be on the nursing floor to help with routine tasks like gathering supplies and gathering PPE and obtaining medications and things like that to try to reduce. Also looking at how do we structure our matrix with more LPNs and more PTCAs to support those RNs and their burnout. So definitely a significant challenge. All right, we're going to go ahead and move on to our next question, which is talking about. So we've talked a lot during this conference about inflation of supplies and drugs and the wage structure. So just wanting to pose to the team, what strategic approaches are we doing around government payer reimbursement, commercial payer reimbursement in light of these additional costs that we have in the market? Ooh, who do I get to pick? Let's start. I'm going to start with Tom on this one.
Thanks, Marni.
You're welcome.
So I think that's a challenge for as we go forward with it. And some of the things that we are doing, and I think we all need to do, is really educate our legislators about the issues in healthcare. Because I think within the state of Washington, hospitals and healthcare systems have a bad view from our legislators. And so I think the educational process to do that. And what we've done is we've engaged lobbyists both on a local level and on a national level to help us tell our story as we go down that road. Third, to be very engaged with the WISHA, with HFMA and AHA in helping tell the story and really feel it out, and really WISH's continued efforts to demonstrate the crisis we are all in. But one of the things that we've also done within to Confluence and with our service region is, I call it my chamber talk. We've developed a chamber talk that really works to educate the employers about the cross-subsidization that the employers, people say it's the payers, but it's the employers paying the premiums, are willing to cover the Medicare and the Medicaid to do that. And we really show at Confluence's results in the fact that Medicaid only covers 57% of the cost of caring for a Medicaid patient. For Medicare, it's about 71% of the cost of taking care of a Medicare patient. So with our small payer mix of 23% insured, we have to charge the employers 189% of the cost of taking care of their patients to subsidize those other two programs to do that. And so one of the things I like to point out to them is that imagine you're in a grocery store and you're coming up to the checkout line and you have a basket full of $100 worth of groceries, and they ask you how you're going to pay for that. And you say, well, I'm going to use my Medicaid credit card. And they say, well, gee, thank you very much. That'll be $57 for that $100 worth of groceries. And then the person right behind you is the Medicare person. How are you going to pay? I'm going to use my Medicare credit card. Well, then you need to pay $71 for that $100 worth of groceries. And then if you're the insured patient with Primera, how are you going to pay for that? Well, you're going to pay $189 for that $100 card. If you sort of take it to that level with those folks, they certainly start to realize some of the challenges that you have with it, and we deal with that every day. We just don't put that out. Now, there's some conversation is that we are actually working with the payers, and some of you know we went to battle with Primera last year, and I won't say we won. I'll say that Primera and I got together and said we did the right thing for our community. But also we're looking at challenging the Medicaid managed care companies, and we're going to battle, and we're looking to get significant increases from what they have paid us in the past, because if you look at their balance sheets and their income statements, they seem to be doing pretty well anyway. And so we're going after them locally to do that, and then also having conversations with some of our payers. Now, I don't think we can expect the payers and the employers to make up the entire difference. I think there's a responsibility that the state needs to really bump up, because for the PPS hospitals to not get an increase in over 22 years is just not right. And I think we need to challenge our legislators that you cannot expect us to take care of more patients, increase the cost, look at staffing levels, look at a lot of different things without doing their share to cover the increased cost of the reimbursement. And for not to get an increase for over 22 years is just unconscionable and disappointing. And I think we should all tell that story. And I think the more that we can tell the story and work with WSHA and other folks to make the difference, but the state has got to step up and do their part.
Yeah, I don't have a lot to add to that other than I go around Alaska just talking to anyone at the state who will listen to me. We have public affairs. At Providence, we have teams who help us with government affairs. We got to get more people to the table, and I'm a squeaky wheel with anybody who will listen to me at the state. I communicate. That's my approach right now. See who will talk. See what movement we can get with the state. But it's a tough battle.
Yeah, it definitely is. I think we've been pretty active this last year with speaking with legislatures both on the state and the federal level, and I do think it's made some difference. Not so much with the payer end of it, although we have been discussing that with them as well. But certainly, earlier in this year, Heidi Anderson, our CEO, was able to really, work with legislators and get some of the provisions that were in that nurse staffing ratio bill changed, and that made a difference. It was really a one-size-fits-all type of bill, and it was really interesting to me, this morning listening to the presentation that Paul Young gave, because it was sort of like, this is what is going to happen. If we wind up doing this same thing, this is what Washington would be looking at. And thankfully, there were some of those changes put in there that allowed and a little more flexibility and postponed stuff for the critical access hospitals. But that fight's not over, that's for sure, and that's going to keep going on in the state. We have to educate our legislators. It needs to be. They need to understand what's going on, and that what decisions that they're making, and how that affects them, how that affects their communities.
I think the only thing I would add to that, I think the comments in regards to talking to the state, talking to your payers, I think that's important. But I think the other aspect is a critical access hospital, cost-based reimbursement. A couple years ago, basically woke up, went to work, found out that the way we've always been reimbursed for RHCs is completely different. Got rid of the increase in your RHC payment, and unfortunately, we were right in the middle of our first major capital investment in building the new MOB. And so the debt capacity study that I'd done and my cash forecast was basically thrown out the window overnight. So that's something we've had to kind of look at, is how do we strategize where we put our costs? How do we strategize how we try and recoup as much of that reimbursement we can through the hospital, through outpatient services, where in the past, you knew you were going to get your percentage of those costs through your RHC. Now we're fixed to an MEI increase each year. So I think looking at the way you do things, at least at a critical access hospital, where you put your cost, how you plan for your reimbursement, how you strategize, you got to stay a little bit nimble, have backup plans.
So Tim, for those in the room that maybe aren't as familiar with RHC and the other acronym you used, would you mind kind of explaining what that is?
I can give you one of them. No. So RHC, Rural Health Clinic, is basically just a designated clinic under a critical access hospital. It can be freestanding or it can be under a critical access hospital. But historically, we would get a cost-based reimbursement, just like you would for a critical access hospital through your inpatient rate or your outpatient percentage charges rate. A couple years ago, they basically changed that and said, we're going to cap your reimbursement rate for your RHCs, and at the same time, we're going to bring up the freestanding RHCs up to a higher rate, because there was a huge price disparity between freestanding RHCs and provider-based RHCs, and the rate was probably too low for freestanding RHCs, and that's why a lot of them closed. So But what that changed for us is the way we strategized, the way we allocated our costs, the way we built our programs, where we provided certain services. That changed overnight. And unfortunately, it was retroactive as well. They actually applied it back to the previous year. That way, previous year became your base year, not that current year. And then the MEI is the Medicare Economic Index rate. So that's going to be set each year. This year, hopefully, it's going to be a little bit higher than in the past, but it most certainly probably will not match the inflation rate that we're looking at.
So, as a follow-up question, knowing that these escalations in inflation, kind of capped reimbursement, the advocacy, the contracting is a very slow process. Can one of you kind of talk to what you're doing to pivot from a financial sustainability perspective? Are you deferring capital projects? Are you cutting other programs? What sort of things are you guys thinking through?
I'll just Confluence, we have deferred some of our capital projects to do that. Some things we had in place, but now we've actually stopped any capital spending going on, and we're in the process of reprioritizing all of our capital projects for the next 3 years, and then prioritizing over 5 years. But we really think we need to focus on the next 3 years as we go forward on the capital side, because it will take, 18 to 24 months to recognize any reimbursement opportunities that we can negotiate as we go forward.
Anybody want to add to that?
I think Providence, I don't think it's any secret that Providence is going through reorganization. They're rethinking the structure of leadership. I think they've done a really good job at focusing on patient-facing as priority, and it's something that needs to be looked at. All capital has been paused, and we continue to do programmatic reviews also. As I mentioned, Alaska is really big at, they call it community investment, so funding and financing specialties that really will never recover the costs. So it's really going through and making sure we're doing programmatic reviews and making sure it's strategic.
That's great.
Yeah, I think for us, I think it's still on.
Just keep talking. They'll catch up.
For us, I think probably our organization is a little bit behind the curve on our reimbursement, and we've been engaging in with partners and with some changes in rebuilding our PFS department, and that is probably long overdue. It's hard to go through, but I think it's where there's opportunity for us ultimately, because we're not getting enough out of our payers. We've probably been taken advantage of by not having the best processes over the years, and we need to correct that internally. And that's been, it's been hard going. It's difficult. It's challenging. We're probably 35-40% there, and have a lot more to go. But I know that we're going to get there, and we've also engaged partners to help us with that, because it's difficult. It's not easy, kind of tearing off the Band-Aid and saying, okay, well, this is where we've got some problems and we've got to fix them. So for us, that's our strategy, because we've got to get. We haven't been good at it anyway, and we haven't had good data either to really negotiate with payers. So we've got to get that fixed first in order to get to the point where I think some of the other organizations in the room already are at.
Great, thanks. Tim, anything else?
I think the only thing I would add is just we've started seeking some alternative funding models, looking at different grants, and it's a little bit easier for us. We're about $40 million in revenue, right? So $250,000 to us, still a decent amount. So similar to what they say, we've kind of paused a lot of capital projects, but if we can come up with some alternative funding, grants, work with the foundation, we've done some grants straight with payers to get some programs off the line. I don't know if you guys have ever talked to a payer about that, but actually just went for a one-time grant type fund. We use that to jumpstart our behavioral health or integrated behavioral health in our clinics. And then probably the other alternative is, or another option is working with some of our vendors for different kind of rebate programs. You have the Clean Energy Standards Act coming up, and we actually worked with our utility company, and they're funding basically a 4-year evaluation of that program for us. We'll get our report out of it, and they'll actually give us some rebates as well for any kind of infrastructure investment we need to make.
Great, thank you. One thing I will add that we're thinking through is being really strategic about our panels on the provider side, and how we fill those panels and how we're filling our schedule, our surgery schedules, and making sure that we've got the right level of diversification, and that we're making sure we're maximizing provider time and APP time. As we're seeking to accommodate the demand that's coming, we've got to create the access. So that's something that we're looking at. Okay, so we're going to talk a little bit about providers. We know that provider burnout is a big thing. We know that our providers, definitely want to be well compensated in most of the conversations I've had with physicians. So in light of kind of some of the stuff that's going on, what types of payment models are you thinking through? Given the financial changes is now an opportunity where you guys are relooking at provider comp and how that's structured. So I'm going to start with Becky if I can.
Yeah, for the Alaska region, the medical group is the only ministry of Providence that actually holds provider contracting. So I'm very familiar with this topic. I don't know how successful I am with it yet, but the conversations are getting pretty difficult. I do have some pretty strict parameters as far as what we can offer on comp models, but it comes down from system, and we do market reviews. So constant conversations about just the changing in market rates, right? Doing market reviews over and over again for certain specialty groups and having the conversations. Really shifting models towards value-based care, putting a portion of their comp model at risk, which is not in the direction they want to go whatsoever. So those conversations are going awesome. But it's getting them to buy into the, where we're going with healthcare, right? Like we want to be on value. We don't have any value-based care contracts, but it's getting them into that mindset, and it's been nothing but an uphill battle, right? And none of them want to be held to production. This isn't going out to any providers, right? Oh, geez. They're wonderful. But it's just an uphill battle, right? How do you get them invested in this whole person care, but still get them feeling like they're getting the comp that they deserve, and they're not going to just go across the street?
Yeah, I would echo a lot of those things. I think the challenge is Confluence Health we're interesting because we have a physician group that it's a separate for-profit company that represents about 95% of the physicians in our communities that we serve. And so we've been on a RVU production model for forever to do that. And one of the challenges since I've got there, we just finished a fair market value study with that to do that and involving the physician. So now there's some conversation about what's fair market value and how much can you do in some of those things. And I'll be honest with you, for a lot of the physicians, that's new to them and an educational opportunity to do that and educating what hospitals can and can't do to go through that. And so we've been through about a year-long negotiation with that. And I can tell you I think I got their final offer in an email today, so I think we are very, very close to do that. But it's been a very painful, challenging process because it does question people's loyalties or what are you trying to do to me if you're a physician to do that. And at the same time, you want to make sure they're being paid fairly and equitably to do that. And of course, anybody who's done this for a period of time recognizing that the two just don't go together no matter how good your numbers are or how bad your numbers are to do that. There's always that mistrust as you go forward with it. But I think, as anything, it's really using the education and taking the time and sit and talk and be patient as you go through that process. And I think showing them numbers, and I think that's been helpful to do that as we've gone forward with it. And then, but also in the process, we did put, for one of the first time, we have 10% of their pay is at risk to meet certain quality community things. And some of those things are not just easy things to get to. Some of it is going to be, what's their HCC RAF scoring? What's their, how are they doing on their panel size? Are they at the right panel size to do that? Are they helping us operate their departments, their clinics as effectively as they possibly can to do that? And then also helping us meet the 5-star quality indicators for our hospitals. We do that. So all of that's different weightings to do that. But I think it's time we have to do that, because value-based care is the future, I think, for everybody. And you really just have to start talking and working with the docs to get them to understand, educate, know the numbers as we go forward with it. And what we have found, though, too, is when you're negotiating with the docs, our docs, there's a certain number of them do that. We've actually now trying to take it to a little bit broader standpoint so we can involve more of the physicians so they understand what's going on. So it's a tough process, but I think it's well worth the effort, because we all, as we talk about at our organization, if the doctors aren't successful, Confluence isn't successful. And if Confluence isn't successful, the doctors won't be successful. And so we are in this together, and we look at it as a team sport as we go forward.
Thank you. Kind of along the same lens of providers, strong physician organizations have a better success rate of being able to drive financial recovery throughout the organizations. Can you guys talk a little bit about what you're doing to engage your physicians on kind of financial recovery efforts and driving culture change through your organization as it relates to the new financial dynamic that we have in healthcare? Mic drop.
I can share a little bit to that, and it kind of ties back to the previous point a little bit as well, but there's no secrets in the end. When we meet at MedStaff, we talk about here's our financial performance as a district. Here's our financial performance on a clinic level. We meet with each physician, and we're small enough we can do this. We meet with each physician when you give them a practice performance. And so we tell them, here's your productivity, here's your gross revenue, here's actual cash collections, right? Because that helps them actually seeing what's collected through the door versus what's going out. And then we talked to them about payer contracts. So we asked them kind of back to what Tom said, as far as they put 10% at risk. We're not quite that point. They're not to that point that they want to put any money at risk, but we have had some upside incentives tied to quality. And then we actually work with them on what quality measures they feel that they can influence the most. And then we build our contracts with our payers for a value-based contract around what they feel they can be successful with. That way they feel that prior to us just saying, here's the contract, here's what you're going to focus on, they feel like they help build that. And that's what we've done.
Thank you. Anybody want to add anything?
I'll just say, I'm sort of echoing what you had talked about, Marni, is we have been working with our doctors we have an access of care problem in the Wenatchee area, and so we have put together a sort of a RPIW team to start looking at how do we improve access. Very physician-led to do that as we go forward with it, especially in the primary care side. So we think we have significant opportunities to improve access through making sure all the physicians we're hitting all our appointment times and all those type of things. The second thing is in the OR, which drives a lot of our revenue. Just to share dirt, currently our on-time start in our OR is 30%. And so there's a commitment from the doctors to get that to 75% in the next 2 months as we go forward. We're using now benchmarks to look at block utilization, OR utilization, and all of those things, and tracking now RVUs by physicians and by specialty to do that, because and our argument with them, if you want us to pay you fairly, then we need to make sure we get work from you fairly to do that. And so it's not necessarily something new, but there's a lot more impetus and a lot more agreement on both sides to hold both sides accountable to hitting those benchmarks.
That's great. Thanks. One of the things we're looking at is because we're part of a large health system and we're, from a geographic perspective, we're fairly close by a lot of our hospitals. And so we can make some decisions around service rationalization and where we provide services, where does it make sense to consolidate services. And in some cases, those physicians don't want to see those cases leave their market, leave their community. And so how do you engage with your providers in those conversations? And maybe it's, okay, we're not going to remove it from the community, but help us come to the table and, look at the cost structure of providing that services and how do we get it to a more profitable place that can allow us to continue to operate that service. So that's been something we've been focusing a lot on as we've been optimizing financial performance. I do want to briefly talk a little bit about the revenue side and payer denials and write-offs, thinking about the waste and the manual work that it takes in those processes. What are some solutions that you guys have worked through or thinking through to create more efficiency within your organization? Let's start with Paul. Paul?
Well, I mean, it's something that we're working on a lot right now. As a member of the Rural Collaborative, we were there pretty early on talking about delegated credentialing, and the whole purpose of that was to kind of accelerate, to do what large organizations do, and accelerate our ability to get paid sooner by payers. That's been a long road too. It's taken much longer than we thought it would. It's had a lot of hiccups, along the way. But I think, we're finally getting to that point where it's starting to work and starting to help us. Our biggest problem internally has just been a lack of good information in order to really evaluate what we need to do and how we need to, fight with payers and deal with the denials. And so that's been, kind of a focus over this last year. We've had to partner with a company to help us understand some of that. We're not at this point actually electronically posting our cash into our system, so, and we've got a very antiquated system. So you've got to be able to use the data. We've had to partner to get that data in order to start understanding, where are we having the breakdowns, because we've been trying to deal with denials for a couple of years and just not getting anywhere. And I think we're now starting to turn that corner, and I think we're, getting changes too, and changes in mentality that, we can go out and fight this. We can go out and we can do something about this. And that's made a big impact, So I think there's upside for us, but again, we're probably several years behind where other people, other organizations were at, currently.
Thanks. Anybody want to add to that?
Yeah, we've developed Josh's favorite scorecard, a payer scorecard that we've developed for all of our payers, Medicare, Medicaid, and our commercial, down to each individual payer. And we've actually used that to talk to the state about Medicaid, especially the managed care companies. We've sent it to WISHA, so they're involved with it. But more importantly, we've been using it with our Medicaid managed care organizations as a negotiation and putting in thresholds. And we started to do that now with our commercial payers on denials and resolution rates to do that. And there's working with some of the payers, we're going to be putting penalties in the contracts for not meeting those targets.
I keep thinking about Day's presentation yesterday and how she was talking a lot about, get your ducks in a row. So our approach at Providence, that was really in line with one of our biggest blessings at Providence is we're big, and one of our biggest downfalls is we're big. We have an entire department that does my contracting. Somebody else is doing, rev cycle. So constantly, it's just get people to the table, the information. We're not getting the information quickly enough back to the people who have the right details of what can we fight. And we're just not in a financial position right now where you can ignore the low-hanging fruit, right? If there's something that we should be getting our ducks in the row, that's where we're focusing right now. If it's avoidable, man, we better start figuring out why, how, and fix it. That's low-hanging fruit in a situation that we're in right now.
Thanks. Tim?
I think for us, this has been a huge focus point in the last year. And we're taking a multi-look approach. We're really kind of working on the front end, educating providers, working with the UR team, so that we're trying to avoid denials prior to getting the denials right, using OBS efficiently instead of just going straight to inpatient. We have some vendor contracts where we have questions whether or not patients going to meet admission. They're not going to meet admission. We'll use those. Any kind of hold patients we're holding in the ER for a longer period of time, we're trying to utilize that OBS status to our benefit, so that worst case scenario, we have a write-off. Best case scenario, we're going to capture some revenue. And then really working contracts. We have some old contracts, kind of like Paul said, we're probably a little bit behind. And so I have some contracts I've really been working. I had a contract that I found, and it's a small payer. It's embarrassing to admit, but it's a small payer with not a lot of revenue. But that contract had been negotiated to be a fixed, our contractual adjustment increased by our increase in charges every year. And when I went and looked, we had a 27% contractual adjustment with this commercial payer, which is crazy for us. I mean, that's so far out of line for what we have for everyone else. So really kind of going through, hammering all the contracts. I sent 3 term notices to payers this year, fully intending on renegotiating, but really that gets their attention, because right now there's no incentive for them to come to the table to work with us unless there's a fear of losing the contract, especially being as small as we are. We can't influence their ability to sell their product within the county because there is another hospital, and we're half the counties within 20 minutes of Spokane. So using our best leverage we can to try and push payers.
Great, thanks. Okay, so then the next part is probably my favorite part of the CFO panel is getting to know our CFOs just a little bit more, kind of on a personal level, and really wanting to understand where what their career path was, and what were the lessons learned in their career path, and then kind of any advice for future CFOs out there, or other things you want people to know about what it's like to be a CFO. So who do we get to start with? I'm going to start with who wants to volunteer? Becky.
Oh, my goodness. I think of myself as an HFMA success story. I don't know if they do.
Woo, woo.
But my career progression, I started in public accounting. I was there for 10 years. And about 5 years ago, I took the jump into industry. And one of the past presidents, Vincent Stevens, I think the day that I changed my LinkedIn profile, he's like, "You're in healthcare? You need to join HFMA." And I was like, "Okay, this is great." And he set me up with a mentor. And I started out in private practice, a small group of providers who wanted to create their own medical group out in the valley of Alaska. And it was a nightmare. I think I learned every single thing that you should never learn about healthcare. And Amy Miller ended up being my mentor through HFMA. And she is the regional CFO of Providence up in Alaska. And I would go to her with questions and all sorts of really neat things. And gosh, having a mentor and just being plugged in with the resources of HFMA is a huge part of my career progression. And eventually she just said, "Will you just apply for Providence?" So I moved to Providence probably 2 years after being in the healthcare finance field, and worked as the regional finance director, reporting to Amy, helping her run all of Alaska. So all ministries, acute, the medical group, all of it, and really having this high-level view of how it works. And then a CFO position opened up at the medical group, and she's like, "Go do it, go get in the operations of it," right? Like, so being a director of finance high level was a lot of fun, learning the mechanics. And then now it's every day, right? We have primary care clinics. We're figuring out how to keep providers happy. How do you help them with productivity? It's been a really interesting, so only 5 years in the healthcare field, but it's been a lot of fun, and I'm learning a lot. I have so much more to learn listening to these gentlemen talk, but very thankful to have the connections at HFMA and be where I'm at. Providence is great.
Thank you. You want to just go down the line, Tom?
Sure. I can go. Being the oldest CFO, but I started and worked public accounting for about 3 years to start with, and I think that's great experience. I never did any healthcare while I was doing a public accounting. I left public accounting and went to work for Gonzaga University for a couple years, and as assistant controller, I found out I couldn't get Gonzaga tickets, and so I left. No, just kidding. But I applied for a job at Kootenai Health in Coeur d'Alene to be their controller. It was sort of an interesting thing. I applied and didn't hear anything for 3 months, and then I figured, well, I guess they didn't want me. Then I got a call 3 months after that, had an interview, and I had the job offer 2 days later, which was entertaining all by itself. So I was the controller there for about 3 years. The CFO left, and I applied, and I was all of, I think, 29 years old then when I was doing it. And they interviewed other folks, and I applied for the job. I ended up getting the job, and the conversation the CEO had with me was, there were probably better people, more qualified than you were, but he said, what you had demonstrated during your short time here for about 3 years, you were engaged, you worked hard, you had the best, you lived the values of our organization. So as an administrative group, we decided we'd rather go with somebody that we can work with and grow with, as opposed to taking a risk and bringing somebody in from the outside. So part of my comment is there, when you're, no matter what job you have, make sure you're involved, you live the organization, you believe in the organization, and you live their values and do it. Otherwise, get out, because it's not going to be very much fun if you don't really aspire and be part of that organization to do that. So I was there for 23 years as the CFO at Kootenai Health. I left to go work at St. Luke's Health or St. Luke's Boise in Idaho, and I was the regional CFO for the Eastern region, which included Magic Valley, Sun Valley. Somebody had to go to Sun Valley a couple times a week to see what's going on there.
Bummer.
And from there, I left as they had a reorg, and I wasn't quite sure what my job was going to look like. I went to an organization, Great Plains Health, in west central Nebraska. And if you've ever been to west central Nebraska, it's a wonderful place. And it had about the same square mileage coverage that we have at Confluence. And the job opened up at Confluence, and I knew some of the folks, and I sort of applied. I grew up in this area and wanted to get back, and I ended up getting the job at Confluence. But some of the lessons learned, other than just living the values and so forth, is number one, hire people smarter than you are. And I think that was demonstrated very much today when they were talking about the No Surprises Act. Josh Wood and Grace and their teams are all over this, and so I don't even have to worry about it because they're all over it, and I appreciate that. But again, hire people smarter than. Second, get out of their way. Trust the people that you hire. Always manage them up and recognize the efforts that they put forward to it. And the other thing I learned early in my career, it's not what you know, but who you know, and where can you get the right answer, and how you get a trusting answer from that. And then fourth is don't let your ego get in the way, because what I've seen throughout my career is a lot of the issues, especially we deal with doctors and other folks, egos get in the way, and we sometimes don't come to the obvious or the best opinion. And what's worked well for me, like I said, is number one, set expectations, clear expectations, key performance indicators, benchmarks, so people know what their job and what they're supposed to do, and more importantly, tie it to the organizational goals as you work with them. Again, trust your team, recognize their accomplishments, and lastly, do not micromanage what they're doing. You hired them for a reason. Get out of your way. Now, if you're going to ask me, gee, was I perfect at this when I first started? And so you learn over time that your team will make you better, and get out of their way and let them do their jobs.
That's great. Thank you.
Well, I've probably had the weirdest career path to getting to CFO. So I'm not. I don't have an accounting degree. I didn't set out when I was a teenager to say I'm going to be a hospital CFO or anything like that. I've been despite this, I've actually had been doing accounting my entire working life. So it's over 30 years of that, and I managed to get into healthcare 18 years ago. I took was able to get the accounting director position at Yakima Regional. And that, at the time they were owned by HMA, so it was a larger hospital than where I'm working now, but also, big corporate environment, for-profit. I coming from a manufacturing background, there were a lot of insights that I had. I knew accounting in and out, but what I really liked about healthcare, and the thing that was very meaningful to me, was its mission. It's necessary for human beings. It's important. And, I've worked for companies years ago that made widgets that, they could stop existing and the world would move on just fine. We work for organizations that they can't stop existing. We need them. Everybody needs them. Everybody needs a hospital in their community, and you need healthcare. We're all going to need it at some point. So that mission, was something that spoke to me very well, and I think it made me invigorated in the work that I was doing. It wasn't just, hey, I'm here crunching some numbers for a paycheck. I'm here to do something that's important and makes a difference for this hospital and for the community at large. I've worked at Deaconess for 3 years here in Spokane, and I eventually wound up leaving and then going over to the critical access side and working in rural health, and that's where I've been ever since. So I've taken these kind of weird paths, but I really found that organizations like HFMA have really helped me a lot, helped educate me. I think in my healthcare career, the first half, I was a member, but I never had the opportunity to go to any of these type of conferences or anything like that, and didn't do a whole lot in terms of education. I did, get my CHFP, towards the end of that, and that started getting me more involved. As I've gotten more involved and come to conferences like this is where you learn, this is where you network, and you're able to keep your mind open. I ask questions. I look. Really a lot of the decisions that I make, I've frequently have vetted them with other CFOs and other people. What do you think of this, and how would you do this, and what do you think we should do? Just because it's just getting that other. It's like Tom said, you put your ego on hold. You got to get other people's ideas and values in there to understand, what's the best decision. I think lessons learned echo a lot of things that Tom has said in terms of build a good team, manage your people up, get out of their way, let them do their jobs. I think for me, the skills that I bring are just problem solving, breaking down problems, and not taking an answer that doesn't make sense and saying, oh, okay, I'll just live with that. No, that doesn't make sense. We've got a problem. We've got to dig into it further until we can find a solution. That makes a big difference, I think, is just being able to problem solve and not taking no for an answer. Just don't do that. You're there fighting for your hospital. You're fighting for the community. And I think putting yourself as, I'm not just here to make a paycheck. I'm here to do something, and do something that's really important for people.
Great, thank you. Tim?
Yep. So I started in public accounting, worked there for about 7 years. So the first 2 years, not doing healthcare, doing about everything but healthcare, manufacturing, banking, lumber mills, all sorts of kind of random stuff. In the last 5 years, I went to work for MRB and then Wifley, and really kind of focused just on healthcare and specifically rural healthcare. And then went to work at Lincoln about 9 years ago as a CFO. So kind of a traditional trend, I guess, in movement into that position. I've been very, very fortunate, I guess, in my career as far as having people who invested in me in all aspects. I still do today. A lot of support structure. I think that's important, and I think that's something to keep in mind when you're looking at your people as well, the people that work for you. Try and correlate that any support you had, how can you provide that to them? I actually feel pretty fortunate to work at a small hospital because we have a very good collaborative working relationship. Paul and I talk quite often. There's several other CFOs I talk with quite often. There's probably rarely a week goes by that I'm not talking to another CFO at another hospital. And through those conversations and those relationships, we try and engage our other staff as well. So we get key players at each of our organizations working together and putting their heads together so we can use more thought process. I think the big thing has been mentioned, I'm just echoing it, but I think getting a mentor or getting a group of people that you can bounce ideas off of, so you're not trying to figure it out by yourself, learning from others, learning smart. Those are the things I try and focus on.
Great, thank you. Just a couple of things I might add. I've had lucky opportunity to have gotten to do a lot of things in my career. I worked at public accounting and then Providence through the corporate structure and then to the operations side and then over to multi-care. I think the lesson learned I had for me was just to be hungry to learn and hungry to grow. So I wanted to do it all, strategic finance. I wanted to learn the medical group side, so I jumped there. I wanted to learn, how to manage costs, the labor side. I wanted to learn corporate compliance. So I think putting yourself in positions where you're putting yourself out of your swim lane and going into other swim lanes and asking to take on projects that aren't your responsibility, but someone has to do them. So be eager to volunteer. I think that's helped. I also set a goal for myself that I wanted to be a CFO by the time I was 40. That was my anchor point. I think I made it with like 3 months to spare. And then I think don't take work personally. It's hard not to sometimes because we're so invested, but realize that it's all about people. I think building relationships is incredibly important, and just continuing to foster and grow those relationships has been really helpful from that lens. So, and just find a good team. I've left many teams that was not healthy for me, and you spend so much of your life at work. You should enjoy the work that you're doing and the people that you're surrounding yourself with. So that may be my advice. So I do want to thank our panelists, but I want to open it up to you guys to ask our panelists any questions that you have burning that I know you wrote down. And Jesse's ready.
I wanted to ask the oldest person up there. Oh, Tom. Yeah, Tom.
Oh, hi, Jess.
Well, I know a couple of you, Tom for sure, and mentioned it. As far as the legislature and getting them involved, educating them, can you share? I mean, I'll go to you, Tom, because I know 40 years. What is a success story that you've had with doing that?
Well, I'll just talk recently, just this past year with Confluence Health. We're building a radiation therapy facility in Moses Lake in Grant County to do that. And we had asked and pushed to the state to say, hey, can you help us? Because I know they'd given Grace Harbor some money from operations and so forth based upon our Medicaid thing. And Dr. Rutherford, our previous CEO, had done such a great job working with the legislators in our community at the state level. Mike Steele, one of our legislators, said, hey, I can't help you in operational side, but I think I have some money in the equipment funding within the state. And he goes, I think I can get you $1.2 million, I think it ended up for this year, and the rest of the $4 million you'd asked to do that next year to do that, because I appreciate it. But he said, I know at the time the state has no appetite to do anything to improve operations, but I can help you on the capital side. And we would, and Mike Steele would not have come to us unless we had not done a good job of creating those relationships with the legislators in our region and with him, and him trusting us that the information that we was giving him. So that's just, to me, is a great example of you never know how it's going to come up, and if you create great relationships with them, they will work and try to find ways to help you, even if it's not what you asked for to start with.
Thank you guys for your time. Do appreciate it. I ask this question every time I get access to a CFO panel, but I think it's a good enough question that begs repeating. So I'm a vendor here, so on behalf of all the vendors here, we'd love to know, not looking for a certain piece of technology, not looking for a certain service line, but what are you looking for from vendors? How can we better partner with you to help you guys, especially in the turmoil that you're facing now? But what are you looking for in those partnerships? And whoever will answer that, we'd love to hear from you guys.
I'll start saying, I think something Marni's talked about is that finding solutions for us to help us improve our processes, reduce the labor as much as we possibly can, because right now, it's not that we're trying to cut jobs. We don't have people to do those jobs, and we need to improve our processes to do that. And really, we think, at least we think at Confluence, technology is one of the solutions that's going to help us get there to help us offset the labor shortage that we currently have.
I think the only thing I would add was just value, right? I mean, that's what everyone's looking for. If the energy and the relationship adds value and it saves time or it saves money or it produces revenue, I mean, that's what we're all looking for. So I think for the most part, anytime we're in a contract with a vendor, it's a quick ROI. What's ROI? What are we going to get out of this? What do we need? Maybe it's not even a financial gain. Maybe it's just a time gain. So that's what we're going to look for.
Yeah, I think echoing the same thing, just saying, what are you going to be able to do for us that we can't do for ourselves? And some things we know we can do and do well, but I need help on plenty of things, and the things that I can't do well. And so that's where you need to be able to answer that as a vendor, is what can you do for us that's going to help us? And time is a big issue. We're under constant pressure. We're always understaffed. Certainly in the non-clinical areas, you're always feeling understaffed and feeling that staffing pressure. So what's going to be done that can help shorten the work and make it easier?
So I would add two things. One, I always look for someone that I have a good personal relationship with, that understands my organization and understands some of the challenges. Someone that, I go to coffee with and, we talk about what's going on. And I will also add, because we work for such a large organization and we're very matrix, it's usually I'm not always the single decision maker when it comes to investing in a new technology or a new service. And so helping me to be able to tell that story in a very concise, easy way, a simple way to my senior leaders, because certainly everybody's dollars are very limited, and we want to be able to partner with someone who's got good ideas, got the spark that can help drive that idea, drive implementation. We've historically invested in a lot of technologies, and sometimes the implementation doesn't go very well, in that the implementation might go well, but then there's not a good sustainability plan. So I'm always looking for a good partner that's going to help be with me in that sustainability plan, not just get me through implementation. Who else has questions? I think we have time for maybe two more.
All right. Oh, thank you. The question I asked, you guys talked about, the physicians earlier, and being in the critical access or areas where it's hard to recruit, even though you have a competitive comp plan. Are you finding it very challenging to recruit physicians, especially, or primary cares to come out in your area to work at your facility?
Absolutely. It is extremely difficult, and where we're at, we're very remote. So and we're really at the edge of the state, so edge of the country. It's very hard to get providers. You have providers that come in and then they're there for a couple of years and their spouse can't get a job and they leave, or they're there and they feel, well, I put in my 2 or 3 years here for my contract, but this isn't where I want to live the rest of my life. So it is very difficult, and much harder. I think you have to have a different, and I think some of our board, sometimes gets caught up in, we just need to get the provider that's going to want to come here and live here forever and all that, and they had that in the 70s, and I just don't know that that's very realistic. I think we have to, we always try to do that. For us, it's selling the community in a way that is appealing to the provider. It's this is an area where you can hunt and fish, and what are you going to do in your free time? The other piece that I think helps us a bit is the provider gets more command over the structure of their practice at a small hospital, in a small clinic. It's not part of a large organization where everything is kind of dictated to them. They have a little bit more say, I think, that sometimes that's hard to deal with, but they do have more say in how their care is directed and how they want to shape their care for their patients.
All right, I think we have time for one more. Anyone else? Yes, Mike.
How does it feel to be the last meeting before golf?
Well, it feels great, Mike, and I'm really disappointed that Josh didn't wear the golf uniform today as a board member to do that. But he claims he lost it. But
Next time.
usually it's the last meeting before drinks. But now you said golf, it's probably even a bigger deal. So yeah.
There you go. Thank you. And just for everybody's knowledge, golf is going to be on Wednesday morning next year, so that it'll bring more people in. So anyway, hopefully get you here early. Thank you.
So I would just like if we could all give a round of applause to our amazing CFO panel. They did an awesome job.